All right.
All right, good afternoon, everyone. My name is Keaton Erickson, and I am the president of the Virtual Pathology Student Interest Group. We are extremely excited to kick off our spring symposium today with the Step 1 prep event with Dr. Maggiore. But before I give the mic over to him, I want to plug the rest of our events coming up. We have 3 more events in this series. Tonight at 5 p.m. Central Standard Time, we have an event, Branding in Pathology. Next week on Monday, April 24th, we have a post-match panel. Next week on Thursday, April 27th, we have an event entitled Follow the Specimen, which is supposed to highlight how truly interprofessional our field is and highlighting different laboratory and pathology careers. And we will post a link to register for tonight's event, the Branding in Pathology event, in the chat. And then be on the lookout for more information regarding next week's events on our social media accounts. And now I will introduce our speaker for today. Dr. Jack Maggiore is an assistant professor of pathology and laboratory medicine and medical director of Loyola University Medical Center's Regional Core Laboratory. In addition, he is a nationally renowned clinical chemist and an educator on the Patholective team. And so with that, I will let him take the microphone. Take it away, Dr. Maggiore.
Thank you, Keaton, and thank you for this invitation today to be part of your Step 1 preparation review session. I've created a Jeopardy game that highlights a number of the categories that I feel are important to cover in your preparation. And today's categories include me, looking at inclusion bodies, cellular inclusion bodies, infectious nature. I'll be providing a description of an infectious pathology, and you help identify the causative organism. Hinge region, this is looking at immunoglobulins, their structure and pathologic process, their involvement in pathologic processes. CPAP, so I'll provide a description of what we encounter in clinical pathology with an associated anatomic pathology finding, and you provide the most likely diagnosis. Catalytic converters, this is all about clinical enzymology, the enzymes that are important to request to assist in the diagnostic process in the clinical laboratory. Urine trouble, these are things that are not good to find in the urine. And here's our board. So Keaton, would you like to get us started with a category and dollar value or point value for our participants? And then just to explain, since we're not in an interactive mode today, you could use the Q&A box to provide your answer, and then Keaton will read those answers to me to facilitate our discussion. So Keaton, where are we starting?
Sure, and just one little housekeeping thing. Right now, I'm not seeing presentation mode, so I think you might be sharing. So I'm not seeing the board.
Okay, let me stop sharing, and then I'll try to reshare.
Okay, great. Okay, great.
All right, thank you. Sorry about that.
Let's start with include me for 100.
Okay, let's get started. This answer is patients with asplenia or non-functioning spleens might have these RBC inclusion bodies.
All right, I've enabled a poll. So we can have a couple of seconds to type in their answer, and then I'll end it in about a couple seconds here. All right, I'll end the poll. All right, share results. Are you able to see the results?
All we see is 100% answered. We don't exactly see what people typed.
Oh my goodness. Okay.
Yeah. Why don't we pivot for now? People who are watching can just submit their question or their answers in the Q&A. Let's see if that works. And are you able to see that, Dr. Maggiore?
I am, and we do have several
great.
correct answers.
Great.
These are Howell-Jolly bodies. So Howell-Jolly bodies are nuclear remnants comprised of DNA, also seen in sepsis, sickling, hemoglobinopathies, lupus, and other autoimmune conditions, and hemolytic anemias. So you are correct that you've identified the Howell-Jolly bodies. Back to our game board, and you see now that we're back to the game board, the hyperlink for include me for 100 is turned yellow to blue, which tells us not to request this again. So Chris Bell, what category would you like us to go to, or what's next? Okay. Infectious nature for 100, this answer is a neonate with severe conjunctivitis has this organism grow on chocolate agar with gram-negative coccobacilli and cocci in chains.
All right, I figured out how to get the results from the poll. And it appears, it opens up in a new window, so I can read off some of the top answers for you guys if that works.
Okay. Okay, we can take a look at some of the responses.
Yeah. Okay, I'll end the poll here. Okay. All right. Looks like the top answers were Neisseria, gonorrhea, and chlamydia.
Okay. Was not the intended response? Any other responses?
Nope, it looks like the Neisseria gonorrhea was the top answer choice.
Okay. Well, the intended answer here is Haemophilus influenzae. Remember, this will not grow on blood agar plates. This organism needs hemin, X factor, and NAD, the V factor, for growth. Haemophilus influenzae is an opportunistic infection. You would also expect to find this in cases of bacterial meningitis, conjunctivitis, as we've shown here, otitis, pneumonia, cellulitis. So these are the opportunistic type of infections. Remember what the opportunistic organisms, they rely on a disruption of the normal microbiome Okay, so a host that might have a viral infection that wipes out the normal flora or the normal microbiome, and then they have the opportunity to infect opportunistically. Okay, back to the board. Any other questions? Excuse me. Okay. Where are we heading next? Keaton.
Sure. Let's do CPAP for 100.
Let's see what's happening in this category. This answer is the clinical lab identifies this disease with restricted bands of monoclonal protein, while bone marrow aspirates show plasma cell clusters. Plasma cell clusters.
And
So
I think
here's
we're
the-
going to pivot back to the Q&A point, back to the Q&A function. I think that worked really well. So let's do that.
Okay.
Sorry about that, Dr. Maggiore.
So you see we have our monoclonal protein and an associated restricted band on an electropherogram for serum protein electrophoresis. And on bone marrow, we see these clusters of plasma cells. So what's your diagnosis? Okay, I see several responses for multiple myeloma, and that would be absolutely correct. Okay. Chris, you were the first to respond with the answer. What's our next category? Where are we heading next? Or what's your next option on the board? Infectious nature for 200. This answer is a thirsty newbie hiker trekking through the Colorado Rockies drank some stagnant lake water and developed a diarrheal illness with a number of these pathogens visible on an ova and parasite microscopic exam. So this is the organism staying with GameStop times 100 magnification. What is this happy looking organism? Yeah, I see lots of responses for Giardia. And you would be absolutely correct. Giardia lamblia, most likely, the most common human parasitic infection that we encounter in the clinical laboratory. Diarrheal illness, sometimes self-limiting, but sometimes does need treatments to help resolve. The Giardia organism attaches to the intestinal lumen through a sucker mechanism just to keep in place while it continues its life cycle and its replication. Okay, back to the board. Chris, you retained control of the board. Where are we heading next? Pin the tail on Giardia. Yeah, we can post something like that next year. Infectious for 300. Let's see what's in the middle of this category. This answer is a 6-year-old boy with thrush is cultured with these colonies appearing on blood agar and this budding finding on microscopic exam. What's the most likely organism? Emilio was very quick to chime in. Emilio is correct. This is Candida albicans. So C. albicans also an opportunistic organism. So it's normally present in a number of locations throughout the body, but in opportunistic events, such as the disruption of the oral microbiome, you would expect Candida albicans to cause infections, including thrush. So good recollection, good identification there. Emilio, give yourself 300. And where would you like to go? you're in trouble for 200. Let's see what's happening in this category. This answer is a urinary tract infection may turn either of these two urinalysis pads positive. So I'm looking for two positive reactions on a urinalysis if we have a urinary tract infection. Tiara, good recollection. Both nitrites and leukocyte esterase, that's the correct answer. Okay, so leukocyte esterase, the WBCs in their granules are going to have leukocyte esterase, and that is going to be able to convert our substrate to a product that's going to cause a violet color change. And some gram-negative bacteria species that most commonly cause UTIs have enzymes that reduce nitrate to nitrite and will cause a pink color change on the nitrite pad. So either of those being positive would be indicative and supportive of a bacterial infection. So WBCs with an auto-reflex 2 culture is a common system that's set up in clinical laboratories to auto-order the culture rather than order a urinalysis with the culture, but to have a reflex set up. Some laboratories use a white blood cell cutoff of 10 cells per high-powered field, and some also include positive findings for leukocyte esterase and nitrite as being reflexive in an ordering capacity. So this way we reduce the number of urine cultures. We reduce the number of urine cultures related to contamination, and more reliably order tests that are going to be indicative or supportive of the preliminary findings. Okay, Tiara, you got that one. Where are we heading next on our game board? Include me for 200. Let's see another inclusion body. Let's see what this answer is. These large crystalline cytoplasmic inclusion bodies are sometimes observed in myeloid blast cells during acute myeloid leukemia and myeloproliferative disorders. Hey, Emilio, very quick to respond, and he is correct. These are our rods. What are our rods? Well, remember what they are and why they appear in these types of infections. They are azurophilic needle-like inclusions that are composed of fused lysozyme, which are rich in lysosomal enzymes. So we can see our rods in not only in AML, but promyelocytic leukemia, high-grade myelodysplastic syndrome. So these are the most common diseases associated with the presence of our rods. Okay. Emilio, give yourself 200. Where are we going next? Hinge region for 100. Let's see what's happening in immunoglobulins. This answer is, this immunoglobulin is most likely to be constructed as a dimer and is rich in mucosal secretions. Okay, good recollection there. Oloasamiglo, you are correct, IgA. So here is that dimer. So we've got two sets of heavy chains and two sets of light chains connected with a joint chain, keeping this dimer together. And in many cases, you'll find a secretory component. So in mucosal surfaces, you would expect secretory IgA to be found. So orally, intestinally are some of the areas where secretory IgA is known to be increased. It's a frontline natural defense. Frontline natural humoral defense. Okay. Back to the board. Oluwaseemiglo, where are we going next? CPAP for 200. This answer is. Laboratory findings of this disease include hypersegmented neutrophils, anisocytosis, very large red blood cells with low concentrations of vitamin B12 or folic acid, with chief complaints of fatigue, pallor, malabsorption, and glossitis. Yeah, our anonymous attendee has this answer correctly. This is a macrocytic anemia, megaloblastic anemia. Okay, good recollection. So remember this collection of presentations, collection of symptoms. In many cases, this is going to start with the manual differential in the clinical laboratory. So with CBC, with the differential, is going to pick up this anisocytosis. And that's going to be one of the first clues, hypersegmented neutrophils. So more than just the 2, 3, or 4 lobes, you're going to see many segments of the polymorphonuclear granulocytes or neutrophils. Okay. Our anonymous attendee, you can remain anonymous and get control of the board. Where are we heading next? You're in trouble for 100. Let's see what's starting this category. This answer is. They say diamonds are a girl's best friend, but as this crystal shaped, let's just say I got it. So here we have a number of these crystals that are diamond shaped in a urine microscopic examination. We see some amorphous structures as well. I see a guess for calcium oxalate. Chris Bell, you are correct. These are urate crystals, uric acid. So remember, uric acid is an NPN, a non-proteinaceous nitrogen compound that arises from purine metabolism. All nucleated cells contain purine nucleotides, and as nucleated cells are turned over rapidly, uric acid is going to be produced as a product, a byproduct of the purine nucleotide metabolism. Therefore, we have to be concerned about uric acid becoming supersaturated in the blood and falling out as crystals. These crystals could deposit in the joints of the big toe or phalanges and form and cause very painful deposits. That's the manifestation of gout that I'm describing. So treatments of allopurinol, treatments of colchicine are indicated to treat gout. But remember, these uric acid crystals could also appear in the urine and also form kidney stones. Okay, Chris, give yourself 100 more. Where are we heading next? Infectious nature for 400, sticking to microbiology. This answer is. A patient with intense upper gastric pain that partially resolves after eating has an upper GI endoscopy, visualizing a peptic ulcer and facilitating sampling, tissue sampling, showing the presence of this gram-negative microaerophilic helical bacterium. What is this most likely organism? H. pylori, our anonymous attendee, is absolutely correct. It is Helicobacter pylori. Generally very easy to treat, but we have to identify it first. And this is not something that's going to grow up in a culture. If tissue samplings are not positive, we may have to turn to other laboratory tests to identify the presence of H. pylori or the increased likelihood. So we can look at serologic tests that look at for the antibody against H. pylori. The problem is serologic tests against H. pylori may not indicate current infection, but a previous infection that's resolved. We may have to turn to urea breath testing using carbon-14 labeling. Okay, so these organisms metabolize urea and form ammonia. So we can measure ammonia that is carbon-14 labeled if we provide carbon-14 urea, and these bacteria then metabolize it to carbon-14 labeled ammonia. So these are the diagnostic tests. We can also turn to stool antigen tests. Okay, so these are becoming more and more popular because they don't rely on a serologic measurement and they don't rely upon breath testing, which could be a little bit cumbersome, especially in outpatients or ambulatory patients. So collecting a stool sample and looking for the H. pylori antigen in the stool is becoming more and more preferred as a way of identifying an H. pylori infection. Okay. So our anonymous attendee, again, give yourself 400 points. Where are we going next? Catalytic converters for 100, clinical enzymology. Let's see what's happening in this category. If negative predictive value is what you seek to rule out liver disease, this is your enzyme. Our anonymous attendee, again, we're going to have to know your identity sooner or later so we can acknowledge. It is GGT, gamma glutamyl transaminase. GGT is going to be elevated if we have either hepatocellular necrosis, in other words, damage to the hepatocytes, or if we have an obstructive disorder of the biliary tree. So GGT, if it's normal, essentially rules out either of these mechanisms of liver disease. So it's a good negative predictor of liver involvement. Okay, give yourself 100. Where are we heading next? Anonymous. Catalytic converters for 200. This answer is, this enzyme is the best indicator of hemolytic transfusion reactions and other causes of cellular lysis. Hey, Nolan, quick to respond LDH. That is correct. So it's lactate dehydrogenase is non-specific. All cells need to have the capability of performing anaerobic glycolysis to convert lactate to pyruvate or pyruvate to lactate depending on the conditions. So all cells contain LDH. Therefore, if we have cellular turnover, cellular necrosis, or in the case of red blood cells, hemolysis, you would expect LDH to be very high in the peripheral blood circulation. So it's a great non-specific but sensitive indicator of hemolytic anemia or a hemolytic transfusion reaction. So for all those reasons, LDH is the preferred enzyme. Hey, Nolan, give yourself 200. Where are we heading next? CPAP for 300. This answer is, a patient with spontaneous hypoglycemia as evidenced by fasting blood glucose falling below 50 milligrams per deciliter, accompanied by mental confusion and dizziness, and is immediately resolved with IV administration of glucose, has a pancreatic tumor localized, shown here, providing this histology. What are we talking about? What is this finding? Yeah, Tiara, very good. So this is an insulinoma. So sheets of trabeculae, some epithelioid spindle cells, although not shown here, these would stain strongly with insulin and proinsulin, but not for glucagon and somatostatin. So more than 99% of insulinomas are going to originate in the pancreas. Remember, Whipple's triad. So this is a classic case of Whipple's triad. We have a patient with very low glucose, less than 50, symptoms of hypoglycemia shown here collectively. So it's more than just being hangry, hungry, or grumpy. It's the confusion. It's the shakiness, the dizziness. Remember, our central nervous system relies 100% on glucose for its energy source. So if glucose becomes very low, eventually we're going to lose consciousness. The mental confusion, being confused, being dizzy, these are all the symptoms of spontaneous hypoglycemia, very low levels of glucose secondary to overproduction of insulin from a tumor. And finally, resolution or relief of the symptoms immediately after IV administration of glucose. So Whipple's triad, know your symptoms, signs and symptoms of hypoglycemia. And again, it's very common functional tumor, which means it's producing a hormone that is functional. So it has immediate and spontaneous actions without having negative feedback and without having any other clinical manifestations that could point to an underlying cause. Good recollection there. So Tiara, give yourself 300. What's next? Include me for 300. Let's see what's happening here with inclusion bodies. A 29-month-old female from Togo on the west coast of Africa arrives in the US with a high-grade fever and presents with these RBC inclusions. So these red blood cell inclusions are identified, reported as part of her CBC with a differential. What do you think these are? Trophozoites, guess for Plasmodium, malaria. Yeah, I was looking for malarial inclusions. And we've got a daily double here. So you can double your point value if you can answer this question. What is the most likely species? So I see a guess for Plasmodium already, P. falciparum. So these are examples of Plasmodium vivax. Okay, so what we saw here were examples of ring structures. So we saw the ring form. We saw some trophozoites, early schizont, and even developing gametocytes in our example here. Okay. Good case, good recollection there as well. And Gita, you were the first with Plasmodium. Where would you like to go next? $500 for include me, top of this category. This answer is in severe bacterial infections, neutrophils and neutrophilic bands may present with toxic granulation and these inclusions. What are these inclusion bodies? See a guess for myeloperoxidase. Dolly bodies from our anonymous attendee. Chris also agrees these are Dolly bodies, and that is the intended response. So Dolly bodies. In this case, we have the knowledge of a severe bacterial infection. So these are remnants of rough endoplasmic reticulum seen in the cytoplasm. The tendency is to see them more in immature neutrophils, like pictured here on the right. Can also be seen in cases of burns, physical trauma, neoplastic diseases, Fanconi syndrome, May-Hegelen anomaly, and leukemoid reactions. But the most common manifestation of Doley bodies is going to be severe bacterial infections with or without toxic granulation and present 1 or 2 Doley bodies in the cytoplasm. Okay, so our anonymous attendee, give yourself 500. Where are we heading next? I'm going to go ahead and clear this category for include me. This answer is lead poisoning or iron overload may cause these clusters of inclusion bodies in red blood cells. So we see a number of these inclusions here. Looks like 5 of them. You see a cluster of 4 here. So what are we looking at here? What are these inclusion bodies? It's a guess for basophilic stippling, sideroblast, so I would agree these are sideroblasts. Tina, Pappenheimer bodies. That was our intended response. These are Pappenheimer bodies. So abnormal, dense, basophilic staining granules of iron and ferritin aggregates. Another name for cells containing Pappenheimer bodies are siderocytes. Sometimes reticulocytes will also include these inclusion bodies. Other disease states where you would see Pappenheimer bodies include myelodysplastic syndrome, sideroblastic anemia, hemolytic anemia, and sickle cell disease. Some of the analytic problems that Pappenheimer bodies present is the over counting of platelets. So certain cell counting analyzers may mistake Pappenheimer bodies for platelets. So automated electro-optical cell counters may overestimate platelets if there are a number of cells that have these inclusion bodies. So we may have to do a manual platelet count in these cases. Okay, Tina, give yourself 400. Where are we heading next? I'm going to go ahead and take infectious nature for 500 just to continue our process. A patient emigrating to the United States through Central America presents with skin lesions and ulcerations of mucocutaneous tissues. Routine cultures produce no growth, but tissue scrapings are acid-fast stained and provide evidence of these bacilli. It's the most common organism that may be causing these findings and appear on acid-fast stain with this type of finding. Full guesses for leishmaniasis, mycobacterial infection, and leprae. So yes, Mycobacterium leprae, the causative organism for leprosy. And we don't see it too often these days, but there's still documented cases of leprosy. Mycobacterium and other mycobacterial infections may not allow for culturing unless you have very selective media. So some mycobacterial organisms may only grow on cell culture type media, like armadillo foot pads and other type of specialized media that facilitate their growth. So very fastidious organisms with very selective growth requirements. So we may not see them grow in a culture. So a wound that appears to be infected, that does not manifest or does not produce a positive culture, may still require a tissue scraping or tissue sampling to look for, and then acid-fast staining would show these types of findings. Clusters of bacilli. Okay, so we had M. leprae. Yep, our anonymous attendee, M. leprae. You've got control of the board. Where are we heading next? Hinge region for 200, this answer is. In serum protein electrophoresis, this region generally contains immunoglobulin G. So this is an analytic question. So we know the immunoglobulin we're looking for. Where would we expect it to migrate? Yeah, Emilio, very good. This is the gamma region. Okay, so our electropherogram shows from anodal to cathodal, we've got albumin, alpha 1, alpha 2, beta 1, beta 2, and then this very polyclonal region that contains the gamma globulins. Okay, so IgG is known to migrate in this gamma region. Very good. Emilio, give yourself 200. Where are we heading next? CPAP. Let's go to 400. That's our next dollar value. A patient with pounding headaches and intense periodic episodes of extreme hypertension. We're talking blood pressure over 200, so 210 over 140, with highly elevated metanephrines and urine VMA, vanillyl mandelic acid. Has this adrenal medullary tumor localized and providing this histology? Okay, we've got correct answers. Mona, pheochromocytoma, you will be correct. So the classic triad of a pheo, episodic pounding headache, palpitations and tachycardia, diaphoresis. So we need to make sure that we're able to provide clinical laboratory support before we do any kind of invasive nature. We can also see this on imaging very often, but it's in the medullary or the adrenal medulla layers. Chromaffin cells, they produce the catecholamines. Catecholamines are going to be metabolized to the metanephrines. Remember, catecholamines have a very short half-life. So we would want to measure their byproduct or their metabolite. So they're metabolized to metanephrines. They're also metabolized to vanillyl mandelic acid. So we can look for either of these compounds in preferably a 24-hour urine sample that's appropriately stabilized with acid, so we don't have more breakdown of the metanephrines. And how would you describe histologically? So shown here are what's called a Zell-Baller pattern, or balls of cells. It may also be seen in alveolar type patterns, trabecular patterns like we saw with the insulinoma, but this is a cellular ball pattern. Tumor cells are polygonal, they have basophilic cytoplasm. There could also be melanin pigmentation also reported in the tumors histologically, but we know we are referring to or dealing with a pheochromocytoma, which has to be surgically removed. Okay, Mona, you had the pheo identification. Where are we heading next? Okay, let's clear the CPAP category for 500. Hepatitis serology is positive for hepatitis B surface antibody and B envelope antigen. And hepatic enzymes show an increase in ALT, 540 units per liter, AST, more than twice the ALT at 1,250 units per liter, slight elevation in alkaline phosphatase, and an elevation in GGT. Serum protein electrophoresis shows beta gamma bridging with an increased IgA of 590 milligrams per deciliter. That's about twice the upper limit of normal for IgA. And a mass is detected in the liver with histologic findings supporting this tumor identification secondary to chronic hepatitis B. So how would you describe this? We've got some bile staining here. We're talking about the most common primary liver malignancy. More than 80% arise with cirrhosis. Patterns could include trabecular, pseudoacinar, but we see polygonal cells with atypical nuclei. Hepatocellular carcinoma. Tiara, you are correct. What else do we know about hepatocellular carcinoma? Well, I'm not talking about tumor markers today, but alpha-fetoprotein may be a tumor marker that is increased in hepatocellular carcinoma as well. It's an oncofetal tumor marker. In our embryonic development, alpha-fetoprotein is the primary transport protein. So before the liver is mature and starts producing albumin, it's alpha-fetoprotein that is the primary transport through the peripheral circulation during embryonic development. Okay, Tiara, give yourself 500. Where are we going next? You're in trouble for 300. Middle of this category, this answer is diabetic monitoring for nephropathy includes regular measurement of this urine protein seeking to stay below 30 milligrams per gram of creatinine. Yeah, Angela and Emilio both have urinary albumin, also referred to as microalbumin. You are correct. So the National Kidney Foundation has recommended explaining to diabetic patients that both their estimated glomerular filtration and their urinary albumin is indicative of the progression of complications, nephrotic injury or nephrotic damage secondary to complications of diabetes. So the green indicates yearly monitoring, low risk of progression. Yellow is still yearly monitoring with increased risk of progression. You see between 30 and 300, this is microalbuminuria. What are we reporting? We're reporting the concentration of urine albumin over the concentration of urine creatinine. Okay, so it's an albumin to creatinine ratio, milligrams of albumin per grams of creatinine. This corrects for how dilute or concentrated that urine sample is. So patients who are dehydrated may have higher urine albumin concentration, but it needs to be measured relative to the amount of creatinine that's in the sample to correct for the concentration or the dilution effects of the urine. And it's just as the colors get more intense toward the red spectrum, it's showing the degree of frequency. So 3 times a year, 4 times a year, and this coincides with the disease progression, the complications. So this is the value of measuring microalbumin. We're trying to reduce the onset of the complications related to diabetes. Remember what those complications are. We've got retinopathy, we've got nephropathy, we've got neuropathy, we've got cardiovascular disease. So these are the primary complications of diabetes, and microalbumin is the way to detect complications that are affecting the kidney, the nephrons. Okay, Emilio, you got albumin. Where are we heading next? Hinge region for 300, this answer is motor oil, like serum viscosity, associated with Waldenstrom's macroglobulinemia, may manifest with this immunoglobulin's blood concentration exceeding 4,000 milligrams per deciliter. That's 4 grams per deciliter. Very high protein concentration, especially of a single immunoglobulin. What's the disease? Or what's it? Yeah, you have IgM. The disease is Waldenstrom's macroglobulinemia, and in this case, we are talking about IgM. It's a pentamer, so 5 sets of heavy chains, and there are accompanying light chains attached with the joint chain, a J chain. So very high molecular weight, and the viscosity of the serum is very thick. So this becomes a matrix interferent. Automated samplers cannot sip or aspirate the serum or the plasma with the same degree of ease as a low viscosity sample. Therefore, we will get a flag on our analyzer that tells us that we may have to dilute the sample for a more accurate aspiration. So this causes problems for us in the clinical laboratory. Okay, Angela, where are we heading next? I'm going to go ahead and stick with hinge region for 400. This answer is mast cell degranulation and subsequent histamine release are associated with undesired functions of this allergic mediated immunoglobulin. Yeah, our anonymous attendee knows we're talking about IgE. Very good. We'll pick up the pace a little bit here to finish on time. Stick with hinge region for 500. This answer is oligoclonal bands of autoimmune immunoglobulins observed when interpreting spinal fluid protein electrophoresis are associated with this neurodegenerative disorder of the myelin sheaths of neurons. Yeah, Nolan, what is multiple sclerosis? And here are those oligoclonal bands. So these are autoantibodies, but there are clones of them, and there's several appearing in the gamma region. So we call these oligoclonal, several related bands. Okay. I'm going to go ahead and do catalytic converters for 300. This enzyme has isoenzymes in liver, bone, intestines, and even the placenta. So which clinical enzyme of interest has isoenzymes in all of these locations? We're primarily interested in liver and bone forms. It is alkaline phosphatase. Very good. So alkaline phosphatase is going to be increased in liver obstructive diseases. We also use alkaline phosphatase as an indicator of bone reconstruction. So this is an enzyme that's going to have activity after we stimulate the new bone growth or bone remodeling, bone healing. Okay, catalytic converters for 400. This answer is, while previously used to diagnose acute MI using its MB isoenzyme, this enzyme activity when measured in the blood is highest in muscle crushing injuries and rhabdomyolysis. Yeah, Emilio, it is creatine kinase, CK, creatine phosphokinase. This converts creatine to creatine phosphate. This is the way that our muscles get their energy, through this enzyme. So when the muscles are damaged, turned over, crushed, injured, You would expect this release of CK to make its way to the peripheral blood. Catalytic converters for 500. This answer is previously the enzyme used to identify prostatic illness, so largely replaced with PSA. But previously, this was used to identify prostatic illness. But when tartrate resistant, let's just say that things get a bit hairy. Okay, so I've got examples here of hairy cell leukemia and Amelia trapped, tartrate resistant acid phosphatase. It's exactly what we're looking for. So acid phosphatase no longer providing much clinical value when helping to diagnose prostatic illness. We have PSA for that. But remember, we still use TRAP in some identification of hairy cell leukemia. Okay, you're in trouble for 400. This answer is, some say it's the most difficult mathematics, but even harder and more difficult to pass in urine. More painful to pass in urine. Isora has calculus, that is correct. So some of the types of kidney stones, cystine stones, calcium stones, uric acid, and struvite. You should know what is in a struvite stone. Okay, so this is a more commonly encountered stone. I don't have a daily double for this, but struvite is comprised of magnesium, ammonia, and phosphorus. Okay, so magnesium-rich stones have this smooth struvite appearance. And we'll clear the board. You're in trouble for 500. These hexagonal shaped crystals may be observed in a microscopic urine exam if this sulfur-rich amino acid cannot be metabolized. So uric acid were diamond-shaped, and cystinuria, angina, and tiara, you are correct. So what is cysteine? Okay, on to our final Jeopardy question. The category is asymmetric butterfly. So we have a question here from our thyroid endocrine category. And this answer is, after a thyroidectomy in a patient with a thyroid carcinoma, these two blood tests are needed to monitor patients for metastases. So we've got an example of a thyroidectomy, thyroid carcinoma, pseudomembrane here. You see normally you've got thyroid follicular or colloid thyroid follicular cells producing this colloid material rich in thyroglobulin. So what are we looking to measure to make sure that we don't have a metastatic thyroid carcinoma? So not VMAs. Iodine. Iodine is needed to construct thyroid hormone, but iodine is normally found in the blood. TSH is going to continue to be normally produced if you are providing synthetic thyroid hormone. So the negative feedback still works with the pituitary. So we're checking to make sure that a metastasis has not occurred. Procalcitonin. Calcitonin. Fine guesses. I see a guess for thyroperoxidase. I may have stumped you here. Okay, so remember, the only source of thyroglobulin are from thyroid follicular cells. No other part of the body makes thyroglobulin. Therefore, thyroglobulin becomes our tumor marker. But when measuring thyroglobulin, we have to make sure the body has not formed an antibody against thyroglobulin. Otherwise, we will not be able to identify it using an immunoassay. So the immunoglobulin that is specific against thyroglobulin is going to mask the ability of our immunoassays to detect thyroglobulin. So we have to make sure we always measure thyroglobulin antibody with thyroglobulin in monitoring patients who have had a thyroidectomy secondary to a thyroid carcinoma. So we would be concerned if we picked up thyroglobulin after a thyroidectomy, we would be concerned that there is a metastasis, a metastatic tumor somewhere producing thyroglobulin. But in order to have that assurance that we're not missing low concentrations, we have to make sure that we are also making sure that there's no thyroglobulin antibody that would mask the ability to detect thyroglobulin. Okay, so this is something that's likely to appear on a board exam because this is all about using the clinical laboratory to monitor for effective treatment of a cancerous condition. Okay, any questions about our review session today? Sorry, I went over by a couple of minutes, but thank you for your participation. I think of the 30 questions, 28 had successful correct answers. So your upbringing in your previous experience has served you well. If you have any questions about any of these review materials, you can get a hold of me through the course facilitators. You can also tweet any of this information, anything you found interesting. And my handle is shown here on the first slide. Okay. I have a few minutes for questions if you have any based on today's experience.
Well, Dr. Maggiore, I believe every single question you had a concept that I remember from my test. And some of these, like Whipple's triad, are things that I remember distinctly were present and were tested directly. So this was extraordinarily helpful. Thank you.
Thanks for that feedback, Nolan. Thank you all for your participation today. I think this will be available on demand or could be watched later, this recorded session as well. So if you have any questions, please get in touch with me. Happy to help.
Thank you so much.
Oh, you're very welcome.
Thank you, Dr.